We're pleased to have Mike Lardieri with us. Mike Lardieri, he's now with the National Council of Behavioral Health, but I've known Mike for many years. We actually worked closely together in Brooklyn for many years when Mike was the lead manager of a large behavioral health program that was in variation of the integration with all of our primary care centers at the Lutheran Family Health Center network in Brooklyn for many years. And then Mike was for several years with the National Association of Community Health Centers before moving to the National Council for Behavioral Health. So, Mike, we're delighted to have you here and look forward to your comments.
Thank you. So thank you very much, Merle, and thanks for having me here today. And hopefully we'll have a little bit of presentation, but then have more time for discussion as we go through some of these behavioral health workforce issues. You see my title right now is Vice President for Health Information Technology and Strategic Development. Sort of gravitated into that role. I've always used technology, so I'm a social worker by background, clinical administration in not only in Brooklyn at FQHC, but inpatient psychiatric hospitals, outpatient clinics, both public and private, and also did a stint in managed care for about 8 to 10 years on the clinical side, and also as Director of Provider Relations for Value Options for the Northeast region, and we managed about 5,000 facilities and around almost 20,000 individual providers from New Jersey up through Maine. Some very large clients, IBM, New York State employees, New York City employees, and folks like that. So some of the issues we had to deal, many of the issues we had to deal with around that were around workforce back then and making sure we had adequate networks for their members to access, adequate both in terms of types of providers and location, but then more than that, availability of providers, and needed to do some checking on that. So we'll talk a little bit about behavioral health workforce. And so, what is behavioral health for folks who may not be that familiar with it? Well, in mental health, you usually hear about depression, anxiety, PTSD, post-traumatic stress disorder. That's connected a lot with the military, but many other folks have post-traumatic stress disorder as well. Bipolar disorder, where folks have periods of depression and manic behavior, and then schizophrenia. That's what you hear about mostly on the mental health side. On the substance use side, you have alcohol and drug use, and then alcohol and drug dependence as well. So there's different variations depending on how you go through your differential diagnosis. And in behavioral health, we use a DSM-4. Now we just moved to DSM-5. In medical, everybody's using ICD-9, ICD-10. Now 10 is delayed, so we're still going to be in ICD-9. They match up pretty well. The differences between the coding is on the ICD-10. It's really just the codes to get paid. On the DSM-5, it actually it actually brings you through the decision tree in order to help you get that differential diagnosis. So in my HIT capacity, when I'm talking to the Office of the National Coordinator and working with the HIT Policy Committee and things like that, we need to make sure that these two data sets are both there. And in a recent, about 2 weeks ago or so, recent meeting with the HIT Policy Committee, and I'm on a number of those policy committee work groups, they're saying, oh, we have ICD-9, we're good. Or we're going to have ICD-10, this was before it got delayed. And we said, well, no, it's DSM-5. Well, they're all the same. Well, they're not the same because DSM-5 actually brings you through that decision tree. And then also health behaviors come under mental health. So smoking assessments and smoking cessation, helping people to stop those habits of behaviors, compliance with treatment. That's a big deal with folks with chronic disease. So how do we get people to comply with treatment? And there's usually some behavioral health overlay with most chronic disease. So we need to work towards that and help people figure out, all right, well, how can I be more compliant with my treatment? I really don't like to take that medicine because it doesn't make me feel that well. And so how can we help you maybe change your times that you take the medication, work with the doc to take it all once during the day instead of a couple of times during the day so you don't forget, those kind of things. And that's where the behavioral health person really needs to work with the physical health provider around compliance with chronic disease. And then the whole issue of screening, brief intervention, and referral to treatment, referred as expert. And that's basically, you usually hear about that around substance use. We want to screen for substance use, but it's really developing to be beyond just substance use. We should be screening for a whole slew of issues when people come into a medical practice. So we want to screen for substance abuse, absolutely. You want to also screen for depression and other behavioral health disorders. But if you go beyond that, we're screening for risky sexual behavior. We should be screening for that. We should be screening for risk of violence as a perpetrator or someone who has been violated. And there are 3 or 4 other ones. So usually if you go into a practice, people have 5 or 6 different sheets with all the different screening tools. And hopefully what we'll get to, and you know, many of us are advocating for this, is to really, let's go to all the screenings on one form, make sure it's all one screening set. And then, you know, if you're in a fee-for-service environment, we'll pay for that screening if you do everything. Once we move to global rates, you really won't have that extra payment, but we should at least get all these screenings at one place. So who provides behavioral health services? A number of different types of providers traditionally provide behavioral health services. So your psychiatrists. So they can be MDs and DOs for your psychiatrists. Psychiatric nurse practitioners. Those advanced level nurse practitioners who specialize in behavioral health, who specialize in psychiatry. You have psychologists, and mostly the psychologists, your PhDs and your PsyDs. You have some EDDs, some educational psychologists who also provide behavioral health services. They'll do that a lot in schools and in university settings. You'll have more EDDs. But if you're a fee-for-service type of environment, or a community mental health center environment, most states don't recognize the EDD as a person who can bill at the highest level of practice, so you don't have many EDDs in those settings. Social workers, you have LCSWs, LMSWs, licensed clinical social workers or licensed master social workers. Different states have variations of levels of social work. New York has a licensed clinical. I'm licensed in New York, where I used to be. I can't maintain my license, so I'm a licensed clinical social worker. And then they have below that is just a licensed social worker, licensed master's level social worker. Other states, the LMSW is the highest level within the state, so there's differentiation even with that, and you have to check with your state to see what it is. The difference with the credentialing is the states then allow for a provider to actually bill for services. So that credentialing, the states in there, usually it's the Department of Education, sets the regulations for who, what kind of provider can bill for services at what level. You have to be at the highest level of your practice in order to bill for services. Licensed professional counselors also provide services. Most states, though, don't pay for them, and if you're in a Medicaid environment, most states don't pay if you have a licensed professional counselor provide the service. You know, they don't get they couldn't bill on their own. And then marriage and family therapists. Again, they're with the licensed professional counselors. These folks also provide behavioral health services. Now then you have a group of unlicensed providers who also provide behavioral health services. So we have master's level psychologists. You have just regular MSWs, may not be licensed, but they may also in a clinic setting, you'll be using those type of folks. And I'll show you, we'll go through a list of the different types of settings. And when you're talking about residential, day treatment, intensive outpatient services, because those services get a global rate, well, then you don't really need to have that highest licensed person because it's the clinic, it's the facility that's licensed. And so they allow a certain number of providers, unlicensed, to work under a licensed provider. Then you have addiction and drug counselors. Those folks are not licensed across the country. They have certification, all right, but they're not licensed. So there's no states now license them. And then peers. So we use a lot of peers. And in the FQHC world, you're talking about promotoras, those type of folks. But in behavioral health, there's a big push to use peers to provide services. And there are limited types of services. With all of these types of providers, not everybody's going to do everything. And so there are still pockets. So the difference between the psychologists and the social workers, they pretty much do the same thing, except the psychologists can do psychological testing. Social workers can't do psychological testing, all right? And if you have a child and adolescent practice, well, then you want to have a psychologist on staff because you're going to do a lot of testing. If you're mostly adults, you don't do that much psychological testing in the adult population. When you get into geriatrics, you may do a little bit more. But if you have a child practice, well, yeah, then you're going to have some psychologists, licensed psychologists, who can actually do the testing. So this just really identifies the shortages. All the, I think just the white areas are where we have people, actually. And everything else, all the other colors, are where we really have behavioral health shortage areas. So it's really striking when you look at that, how much a gap there is. So let's talk about the different types of treatment settings. Assertive community treatment, these are people who go out to the community, reach out to folks who are severely impaired, not able to make it to clinic, and outreach in the community. You do assessments and referral. That could be a clinic setting. That could be on the phone. You have care management services. That could be on the phone, out in the clinic, all over. You have community integration, day treatment. Day treatment is a setting where people go there, usually for about 4 hours a day. Sometimes you'll also hear that as partial hospitalization. So it's usually a step-down type of situation where a person comes from acute care. They're not quite ready to reintegrate into the community. They need more intensive treatment. They'll come down to partial hospitalization. And that's like a short-term thing, though. It's a partial hospitalization nowadays doesn't go on for 6 months, 10 months, 2 years, the way it used to. Now it's like you're going to be there maybe 2 weeks, and then you're going to step down even further. Certainly detoxification. We're involved with the court system with behavioral health. So you have drug courts. So you have people at the courts who the judge will, I used to run a program in Queens that we put ourselves at the court. It was happened to be a domestic violence court, not a drug court. We started working with the drug court. But we were in the back. The judge heard the case. He gave the person, if it was appropriate, the opportunity to either go to jail or go to treatment. And if you want to go to treatment, go see them back there, and they'll bring you to treatment. Now, what we do there is we do treatment, but then we have this ongoing back and forth communication with the court system to provide them information about the patients continuing in treatment, not continuing in treatment, how they're doing. We send a report back to the judge before the person goes for their next hearing so that the judge has that in front of them. And then the judge can then say, okay, fine, continue in treatment, or if you're not compliant, you go to jail. It's, it's just the way it is with some of that. So drug courts and domestic violence courts, substance use courts, same type of thing. We have emergency room diversion plans, diversion programs, excuse me. So those will not only be, not really a 911, but imagine someone's connected with your emergency room, and when the emergency room gets a call and they can tell it's a behavioral health person, or if someone walks into the emergency room and they know it's a behavioral health disorder, they pick up the phone, or someone's already there in the emergency room from a behavioral health organization, and they go do the interview with the person. And then they can help identify for the emergency room. We can actually manage this person. We'll give them an appointment tomorrow morning at 9 a.m. We know they'll go there. They're compliant. They're agreeing to go. And with that type of intervention, the person doesn't have to stay in the emergency room. They'll still be safe. You don't have to have an emergency room visit. You don't have to have probably a hospitalization. Whereas if you didn't have that intervention right there at the emergency room, then you would have a hospitalization, and you'd stay 2 or 3 days just because it takes that much time to figure out what's going on, where that whole cost could be avoided. And it's not good for anybody to be in the hospital. We all know that. We work in employee assistance programs in federally qualified health centers, with homeless services, certainly inpatient treatment, residential supportive living situations, and home and community services. So there's a wide range. So anything that you could think of in the medical side in terms of the range of services, well, we do the same thing in behavioral health, and maybe a little more with the drug court involvement, because I'm not sure if there's any drug courts that involve with medical, so you're not going to have that on the medical side. So traditionally, behavioral health and medical services, they've been provided in silos. You know, it's always been, you go to the medical provider and you need behavioral health services, well, here's a card, call them, you go call them. We know that doesn't work. The studies have shown 50% of all the people who you send out the door in a referral, they disappear. They never show up. So integrated care is a better model and is really becoming the norm. So we do, SAMHSA supports a large program that the National Council runs to help behavioral health providers integrate medical services into behavioral health. And then we also integrate behavioral health into medical services. Federally qualified health centers, you folks are mostly familiar with them. They provide a great deal of behavioral health services, not enough. And Emily's done some work on that about, you know, all the gaps that are still out there. They're not actually meeting the capacity or the demand for behavioral health services in the federally qualified health centers. They serve about 1 million people for behavioral health disorders. They serve around, I think it's 350, 400,000 people for substance use disorders. In your general population, you have 10% of all your people have a mental health disorder, 10% have a substance use disorder in any given year. So of the 20 million, FQHC should actually be serving 4 million people, not 1 million people. And even if you discount some of the coding that comes in, they're still not meeting capacity. So big gaps there as well. So integration is really required if you're going to do any of the new things that are coming down the road and required by the Affordable Care Act, collaborative care, patient-centered health homes, or just health care homes. Many states are now have identified programs under waivers for just health homes. A little different than patient-centered medical homes. Health homes are really based in behavioral health organizations, but they're also required to take care of the medical conditions as well as their behavioral health conditions. And then accountable care organizations need to have behavioral health. What we're finding now is many of the ACOs who've started over the last couple of years, they haven't had behavioral health involved, and they're not making their shared savings as much as they should. The ones who have identified behavioral health as an issue and have integrated behavioral health, Montefiore is one in the Bronx, they're doing very well. And so they've made sure that they've integrated. So many of the ACOs are now saying, okay, we know we need to integrate behavioral health, so how do we do it? Where do we get the behavioral health providers? How do we integrate them into our system of care? So, you know, we need to bring all those pieces together, and whether we're talking about health insurance plans, they have to have behavioral health providers involved. All the regulations are moving towards integration. We still have, you know, the apple's not all together yet, because even when we talk about integration, if you look at the Medicaid side, I think only about 27 states pay in Medicaid, pay for a behavioral health and a physical health care visit on the same day. And so to tell a patient, come back in a, you know, if you're in an FQHC or in a medical provider, you know, I can't serve you today because we're not going to get paid for it, come back tomorrow, 50% of those folks not going to come back. So it doesn't make sense to begin to actually do that. And so, you know, we are trying from the National Council and other areas to educate those state Medicaid directors who don't allow same-day payment to actually allow same-day payment for a medical and a behavioral health service on the same day. So a good framework to evaluate whether there's integration is this framework here. And we look at integration in a number of different areas, from access, services, funding, governance, EBP, evidence-based practices, and data. and from the minimal collaboration all the way through fully integrated. So on access, minimal collaboration, where you really have two front doors, you're separate entities, and patients go for the medical through one door, they have to go out and go for their behavioral health through another door, versus a fully integrated program. The patient just comes in one door, you take care of everything for them. And look at this all the way down to on the evidence-based practices. Folks familiar with the PHQ-9? It's a personal health questionnaire. It's 9 questions to evaluate whether you have depression or not. And then IDDT is integrated dual disorder treatment. So that's if folks have dual disorders 2 ways. If you have a medical and a behavioral health disorder, or if you have 2 behavioral health disorders. You have a mental health disorder and a substance use disorder. So that's 2 different ways of identifying IDDT. So this is a good framework to use if you're in an organization and you want to begin to look at it and say, okay, how integrated are we? You know, and begin to evaluate yourself using this model. However, even using this framework really misses the mark, because the only thing it talks about is being together, physically located together. And in this day and age, we're beyond that. Transitions of care happen like this. And this is a slide I borrowed from somebody else, but they didn't even include behavioral health on here. So, but this is usually what happens when someone goes through the system. They just bop around. There's no coordination or anything about it. And so we need to think about where do we actually need to be. So when you think about where we need to be, I think we need to now think of virtual teams and a virtual workforce. We no longer have to be in the same room, in the same building to treat the same patient. All right? We can connect through telehealth, through telemedicine. Almost had a situation where I couldn't be here today. I was going to Skype in or use GoToMeeting. We can do that with patients and do telebehavioral health with patients. It's easy. I mean, there's a little camera on here. We don't need sophisticated technology. You can do it on this. All right? It's not like we're looking at a baby with a rash and you need that really high focus camera. But for behavioral health, we can use this kind of technology and make it work very easily. So we need to think in terms of this. All right? So this is where we really need to be when we look at our workforce, because unless we get to this, we're not really going to be able, we're never going to have enough workforce. All right? And if you look at that map with all those pockets of areas where we have gaps, the only way we're going to be able to fill those gaps are with virtual interventions and using other technology tools to do assessments and things like that. Let people do these assessments on the web and then have the providers have access to those assessments. Let the people do the assessments over time. So if you do your depression screening, instead of viewing it as a one-time tool when the person comes in, it could be used as a recurring tool. Ask your patient to do that every week or 2 times a week. And then you review their responses, and then you can graph over a period of time how they're doing. And if they're stable, I don't necessarily have to call them in every week just to check them, because that's what we do in behavioral health a lot. Because we're unsure of the person's symptoms, we call them in. We may do a 20 or 30-minute session just to check to see how they're doing. So if we can begin to do some of this stuff virtually, tied into your electronic health record, we can actually stretch out the workforce. Because what we can then do is either provide more access to more clients coming in the door, or we can spend more time with those people who are more severely ill. All right? Now, I don't know which we'll do yet, because this is not pervasive across the country. Everybody's not doing this enough yet for us to tell. But those are the opportunities, and those folks who have begun to use telemedicine are showing great promise with it. So when we look at workforce in our minds, we need to begin to think about virtual and how do we tie everybody in together. And that's going to take electronic health records, it's going to take technology, it's going to take health information exchange. So as we move towards this model, and whether we're of integration, we actually, and whether you're doing virtual or face-to-face in the same building, we need to begin to look at what are some of the core competencies that some of the team members actually need to have. So in behavioral health, now, in the behavioral health area, we're checking for blood cholesterol, we're checking blood pressures, we're doing skin exams, we're doing glaucoma tests. We never used to do that 10 years ago in behavioral health. But now we have to have those competencies about knowing about this stuff, because now we're in an integrated environment. So there's some changes that are happening. And if you look at what staff need to know, well, they certainly need to have an introduction about what integrated care is, and that's both for behavioral health and for medical. Many of our providers have no idea, all right? I have to tell you, they have no idea what integrated care is. It's not like, oh, you know, you need behavioral health, go down the hall down there, go see Miss Jones. Not you, another Miss Jones, sorry. So, you know, you can't, that's not integrated care. Integrated care is, oh, I think you have a behavioral health problem. Let me introduce you to my teammate here, and I want you to talk to him or her about this problem, and then we're going to communicate, and we're going to talk to the other members of the team, and then we'll work with you to resolve your issue. That's integrated care, not just sending somebody down the road. So we need to know on the behavioral health side about the chronic care model, new to behavioral health, many behavioral health providers. We need to know motivational interviewing. That's something both physical health providers and behavioral health providers need to know about. On the behavioral health side, eating disorders, we've known about that for a while, but we need to be focused also on obesity, asthma, communicable diseases, and smoking cessation is a big one. We really haven't picked up that in the past. Now we are in behavioral health. And so all these things that are new to behavioral health are learning medical terminology, where when we are in our own silo, all right, you go to the medical guy, I don't know, you know. We can't do that anymore because it all ties together. We never should have had this split between the head and the body. I've been sort of fortunate because even when I first started, I worked with physicians on a regular basis. I used to do biofeedback training and as part of my therapy, and that was with folks who had headaches and had backaches and had concussions and other things like that. And so I never thought that why should we be any different? So I was lucky. Most behavioral health providers are not. So it's a new training process for them. And it's a new training process for medical as well to now say, oh, these are services that are available. I don't have to spend all the time. If I open up this box and if I ask the patient this question, I don't necessarily have to be the one that spends the time with the patient. That's a lot of why medical providers don't ask the questions about depression or substance use. They don't know what to do with it. And it's okay, you can grow up that way. It's not your nature to be able to do it, that's okay. But you have a team member who can do it. So use that team member. And once you begin to use that team, then you have a workforce that's going to be able to actually meet the needs of the client, because then it's teamwork. And so the medical provider doesn't have to use up all of their time or an extra 15 minutes. They actually just need to be able to go knock on the door and introduce the person to the behavioral health provider, who will then handle that situation for them, and then they'll communicate back. They'll communicate back. They'll communicate back. They have to communicate back. If they don't communicate with each other, the whole thing doesn't make any sense whatsoever. So you have to have that communication. So the huddle, you know, in patient-centered medical home, that's just part of what happens. Every day we huddle, we talk about who's coming in, who needs what service. We look at the charts ahead of time, either that morning or the night before. We prepare, we know who's coming in, and we know if somebody hadn't had a test and they need to have a test, we know who's going to be responsible for making sure that happens. On the behavioral health side, we're not so used to huddles. We're used to an hour and a half sitting down 2 or 3 times a week talking about 5 cases, which is much different. That doesn't work in a primary care setting, all right? And if you try to bring a primary care provider into that, they go crazy. It's like, hey, I got things to do. What the hell are you doing here? You know, we can't spend the time doing this, all right? So there needs to be some training on both sides. So we need to learn how to do these quick little huddles back and forth, have that communication with the medical provider. So that's something on the mental health side or behavioral health side that we need to learn how to do. We need to learn how to tolerate how someone knocking on the door when we're in a session with somebody, and we may not have a desk in an office anymore. We're going to be having we're going to be in an exam room, and we're going to be doing our 20 or 30-minute session in the exam room. So we need to get comfortable with that. And then somebody's going to knock on the door when they're in and say, you know, I have a crisis. You need to see this person when you're done with that. And not say, oh, you can never knock on my door. You can, well, that doesn't work anymore because we're not doing long-term psychotherapy the way nobody's lying on the couch anymore. So there's some core competencies that we need to have pretty much across the board. There was some work that was done by the Center for Integrated Health Solutions. This was run by the National Councils, funded by SAMHSA. It's a training and technical assistance center for behavioral health organizations across the country who are doing this bidirectional integration. So some of these core competencies was certainly the interpersonal communication, collaboration, teamwork, screening and assessment. I'm not going to read them all, but if you look at these things, you would say, well, oh, yeah, well, why did we pay money to even study that? You know, I think that a lot. This is like just, to me, it's like, of course you want to have these competencies. Of course you need to communicate. Of course you need to look at the patient as a system, all right, and what the system is doing for you and who in the system can do what for the patient. So they seem rather obvious, but we did write a report through the center around the workforce, and it's all around these core competencies. This is the web link to that. And then there's, we need to look at, well, what makes an integrated team? I did some work with a couple of folks just recently, and so we have what are the core elements of an integrated team. And this gets to be a little bit of an eye chart, but you can expand it when you get home and begin to look at the PowerPoint. But the way this works, this word cloud, is that the larger font is the more important aspects, the bigger themes, and then it breaks down. So leadership and organizational commitment. If you don't have leadership and organizational commitment to this whole team approach, it's not going to work, right? You also have to take time to develop your teams. You have to measure outcomes. You have to measure the team process. So it's not just the outcomes for the clients, but you have to be on top of what's happening with the team process. How do we make sure that we are communicating with each other in the right way and that we're effective in our communications? So that's a little different than looking at the outcomes for a client. So you need to, we found that from these themes. We actually interviewed about 6 different organizations. They're all HRSA-funded organizations, FQHCs, HIV/AIDS clinics, and rural health centers, and that had integrated teams. And these are really the major themes that came out. And then it gets a little deeper in there. If you wanted to read that paper, you can go down to this link here. So if you want more information about the Center for Integrated Health Solutions, we have a ton of information about integrated care, workforce, financing, all that kind of stuff. So you can go here to the integration.samhsa.gov. Sometimes we have too much. There's a lot of information in there that we just keep adding and adding and adding. So in my mind, I think we get too much at points.